We're good to go. Okay, welcome everybody. My name is Callie. I work with Promises. I'm on the marketing team here. We are in our ninth webinar. We've started these in December of last year. So welcome back to everyone that's been here, all the new people. We will continue to be having these webinars through the end of the year, and we've already started on next year's content. This month's webinar, we have Dr. Gwenn Swift. She's our Corporate Director of Family Services. Gwenn is a licensed marriage and family therapist and holds a doctorate of couple and family therapy from Drexel University. She's also an adjunct professor at Drexel and has taught the Person of the Therapist training program for students in the master's program there. Gwenn is passionate about a systemic approach to treatment and recovery, education and trauma and the brain, and relationships. I will also mention that Gwenn, and if you were in Wendy's webinar a few months ago, they are a team that works on our weekly webinars for our family services program. So anyone that comes to a Promises facility, the family is welcome to join virtual meetings every week, twice a day, actually, or twice a day, once a week. I said that weird. And I'm going to post a link to that page where you can see all of their services. Anyone can join them. I'll just put that in the chat for you all. And you'll see every Tuesday and then every Monday they have webinars. So it can be about codependency, it can be about the brain, relationship skills and recovery, and then there's a general welcome to treatment. So and you can share this page with your clients. And they're live with Gwenn and Wendy every week. So those are really wonderful services that they offer. Gwenn, you want to hit the next slide? So again, about Promises, we have treatment centers all over the country. We're actually going to be opening up a new treatment center in Dallas next year, which is exciting. And then we have Atlanta and North Star are new to our treatment centers of our services as well. All of these offer evidence-based programming and trauma-informed treatment and family services that are really integrated and involved. So if you want to learn more about Promises, you just go to promises.com, or you can reach out to me and I'm happy to send brochures or other resources that you might be interested in if there's a particular area that you cover. So you can hit the next slide. For our CEs, I know everyone is very interested in knowing how they get their CEs today. You have to stay for this entire training. So often, if you are here and you're hearing me say this from the beginning, you'll be fine. We just ask that you don't miss. It's really closer to 10 minutes of the training. And I track that through what time you entered Zoom and what time you leave the Zoom. So if you're already here, you're probably fine. But something else I want you to think about is you cannot be sharing a screen with someone else. So like it's a sign-in sheet. If you were going to attend a webinar or a training in person, you both would put individual names down. So I need everyone to be either on their own phone or computer. You can't be sharing equipment today. And then another thing I want to mention, after the training, you'll get an email from Jotform. So you won't be seeing it from our Promises email. It comes from Jotform with a survey. That's just the tool that I use. And you will have this open until next Friday. So it has to be done within a week of when I send it out, which will be later today. It does take me a couple hours to send this out. So if you don't see it right away, that's okay. I have to go through the sign-in sheet or like our registration and attendee list. And if you jump from like a computer to a phone, I add up those times to make sure that you aren't missing some of your attending time. So that takes me a little bit of time, but it will come out today. If you do not see a Jotform email by Monday, go ahead and send me an email just to make sure. We oftentimes see that Yahoo, Comcast, Hotmail email addresses don't really like my Jotform emails. If you're getting them, great. If you don't see it by Monday and you have a Yahoo email address, that's probably why, and I can help you make sure we get that over to you. Once you complete the eval, it will automatically kick a certificate to you. So if you do not see that certificate come through like within an hour, let me know. And it sometimes just gets stuck in your spam again, or I can just resend it to you. Any other things like our recording today, the slides, other resources that Gwenn will mention, I will send out next week. It goes into a separate email. Anyone that's registered, even if we're not able to attend today, they will see all those resources. I think that's it. And I'll just say to someone that asked if when they moved from phone to computer, yes, if you move from your phone to your computer back to your phone, Zoom will keep up with you. You don't have to worry about it. As long as you're not taking like a 30-minute break between the two and you don't have anything on. So you should be good. Okay, you can hit the next slide, Gwenn. Upcoming trainings. I will also put these in the chat for you all. The ethics of well-being, we're back with Trish, who is the leader of these webinars. She's the one that started all these trainings. And if you've heard Trish speak before, you know, she's not someone you want to miss. She is very passionate about what we do here at Promises and what she's created. And then coming in October, we have a duo speaking to us that day with Rhonda and Megan, integrating ASAM and locus and persons in documentation treatment planning. So if you attended Jamice's webinar last month about treatment planning, met Rhonda and Megan work very closely with Jamice. So if you enjoyed that training, you'd really like this one in October. And then all of our upcoming trainings, again, fourth Friday, except for this one, fourth Friday of every month, we host these webinars. So I'll post also the link to our Promises webpage that has more of the webinars listed. Next slide. Oh, all right, Gwenn, I'm handing this over to you.
All right, this is me. Thank you, Callie. Thank you for all of your support.
Yep, I am here if you need me.
I appreciate that, and I likely will. So welcome everybody. As Callie introduced me, my name is Gwenn Swift. Again, I'm a marriage and family therapist, so my lens is always through emotions, is through relationships, is through connections. And so today we are going to be talking about a number of things. Here are some of the objectives. I'm not going to read through them. You likely will understand them as we go through this. This webinar is really about befriending our own stuff, right? So when I say stuff, I mean our attachment patterns, our emotional reactions, our generational history, our own relationship with mental health, right? Is befriending all of the stuff that we have in order to best support our clients' ability to heal through community and connection and relationships and connection to themselves, right? So just as sort of an overview, you know, no matter what space you work in, whether it's with people directly, whether it is in supervision, whether it is as a therapist, whether it is as a behavioral health technician or a recovery support person, right? If you are in the business of working with people, right, we are all kind of governed by different boards, different licensures, right? And we hold a standard to do no harm. We hold a standard to operate in the most ethical way that we can with our clients, with our people that we work with, right? And so a huge way that we're able to ensure that happens is by attuning to our own selves as human beings, right? Because as humans working with humans, we come into these interactions, into these sessions, into these groups with all of our own stuff, right? And a lot of times we think like, uh-oh, we gotta push all of that over here, right? But I'm actually here to say today that all of the stuff that we come into therapy with, that we come into client and person interactions with, is actually a really good thing. And we need to be attuned to it. We need to be in relationship and communication with all of that stuff, right? So again, today we are going to speak through the lens of attachment in order to best support our clients in building their own relational capital in their lives. So there will be 3 parts to this webinar today. The first is self. So when I say self, I mean us as therapists, as counselors, as recovery support coaches, as recovery specialists, right? The second part is going to be relationships, as in our clients' relationships with all of the different people in their world. And then the third is some more practical information about integration of those two, right? So I thank you to Callie, found this beautiful website that has all of these pictures of lovely humans on it. So I hope you enjoyed these pictures throughout the presentation today. So this is really, again, about attunement and discernment, right? So attunement involves our awareness of and our responsiveness to our own needs, emotions, body sensations as human beings. And I'm going to use the word therapist kind of throughout this, but just know when I say therapist, I mean any position that you may hold working with people, right? So the experience of being connected to yourself is really what attunement is about, right? Which in turn allows us to be connected to our clients, to other people. And discernment refers to our ability to make insightful judgments and decisions by perceiving and understanding subtle nuances, right? In our own self and in our clients. So I have this quote here to start by Virginia Satir, who is one of the founding members of family therapy. She's really fantastic. And it says, can we accept as a given that the self of the therapist is an essential factor in the therapeutic process? Right? So let's talk a bit about self of the therapist and why this is important. So let me first say that I'm going to bring forward a whole lot of content and information here in this next hour and 40 minutes. All right, so I want everyone to pay attention to your own thoughts, your own emotions, your own physical reactions throughout this period of time, right? Because there may be times when you hear yourself thinking, yikes, I have to do all of these things in order to be a good therapist, or times when you feel a knot of stress in your stomach, or times when you are feeling frustrated and hear yourself thinking, this is all crap. All right, today's webinar is not about defining what a good therapist does or does not look like. It is about self-reflection, growth, and awareness. And I've never met a therapist who doesn't want at least one of these things, right? And if you don't want any of these, then you might be in the wrong webinar. You might be in the wrong field. So first, let's define the self of the therapist. So the concept of self for a clinician refers to our personal identity, our values, our beliefs, our life experiences, all of the things that shape who we are, both as a human being and as a professional in this field, right? So in therapeutic practice, self of the therapist refers to our own self-awareness, our understanding of our biases, of our triggers, of our clinical limitations, right? So this awareness helps us to maintain professional boundaries, manage our own emotional reactions, and be the most effective that we can possibly be in working with our clients, right? So why is this important? Why do we need this? We need to be attuned to what is happening inside of us, right? Because as we're going through the therapeutic process, consider this for your own position, right? If you are in the clinical world, if you are a recovery coach, if you are in admissions, if you are in any position working with humans, right? We all have our different reasons for being in this field. We all have our different reasons for showing up at work every single day the way that we do, right? So let me start by reading this Ken Hardy quote. He says, it's hard to separate the personal from the professional lives of the therapist, that the process of becoming sensitive begins with how each therapist lives his or her, and I'm going to add their life. Once change occurs on this level, it will be manifested within the therapy process. So many different people have their perspectives on how distinctly different their personal self is from their professional self. Right? So some people might say, these are one, these are intertwined. I am the same person when I show up in a session with a client as when I'm on the phone with my friends or with my family out in the world. Some people might say, I am two separate people, personally and professionally. I'm one in my personal setting when I am with my friends, my family, whoever, and I'm a different person when I show up for work, right? So we're not here to say that one's good, bad, right, or wrong, right? It's about raising awareness of how you conceptualize, right, your own personal and professional self. Right. So there are many different people who have contributed to the view of self within the clinical world over however many years this field has been in place. Right. So this is not by any means an exhaustive list of all of those people. These are just a few central figures to the story that we are going to tell today. So the people who I am speaking about in this slide today, right, have all had something to contribute to the view of self in the therapeutic process. So let's start with Sigmund Freud, a pretty obvious place to start. He was with us from 1856 to 1939, and his big contribution to this specific topic was the word countertransference. So the first time recorded that this word was used was in a letter to Carl Jung on June 7th, 1909. Right, so Carl Jung had written to Freud his experience working with a young female Russian patient, and he was like, oh, I have some feelings, something's going on, right? And Freud wrote back to him talking about countertransference and the experience of personal feelings coming into the therapeutic process, right? So according to Bruce Fink, countertransference has been characterized as the redirected sentiments of a therapist towards a patient and the emotional entanglement that might arise with a patient. All right, so this term has come with historically mixed reviews. Some training programs, some supervisors spend a solid amount of time really devoted to the experience of countertransference, trying to understand what's happening with countertransference, and some pay it little to no mention. Next, we have Carl Rogers, right, who is a big heavy hitter in the field of therapy. Now, Carl Rogers was interested in the development of the whole concept of self within his clients, right? So this means attitudes, beliefs, values, everything like that. All right, so in a 1960 interview, he was discussing the role of a therapist in treatment. He says, the most valuable kind of help that I can give is the kind of psychological climate or psychological atmosphere that I can create. Right? He says, I have to face the fact that I am the instrument which is most important in my work. So, what about me? What about myself as the therapist? Right? He pauses to address his other instruments of treatment, right? A chair, a box of Kleenex, right? A tape recorder. He says, these things almost never fail. I'm the one that I better think about the most. It's my attitudes which are most important here. All right, now he goes on to explain that whatever he is experiencing needs to be known and open to him as a person. Right? This is necessary for him to be really effective with his clients. Right? He believes that a therapist really can't be helpful to himself or another person unless he could be true to himself as a human. Right now, we could probably spend the rest of the time in this webinar debating and discussing, as a room full of people working with people, the words of Carl Rogers. But I think one of the big takeaways from bringing him into this conversation is to really position the therapist as an active participant in the therapeutic process, which in turn warrants real considerable attention to how exactly we show up in this process, right? So when we are inauthentic, right, when our inside world does not match what we are giving to the outside world, our clients are often incredibly attuned to this, right? Our clients, especially our clients who have experienced significant trauma, right? The part of the brain that is scanning for danger and threat and changes to the environment, right? They are incredibly perceptive to changes in the person who is often their experience of a sturdy base, right? So next we have John Bowlby. So John Bowlby was most known for attachment theory, which concerns the formation of emotional bonds between people, particularly in childhood. He was also concerned with the effects of a person's attachment history on emotional regulation, as well as aspects of their personality. So according to Bowlby, at birth, we have what he calls an attachment behavioral system. Right, so this centers around our ability to be loved, to be cared for, to be protected. And especially as babies, as children, right, the person who does this caring, loving, and protecting is called an attachment figure. So over the course of someone's life, the system inside of us adapts to attachment figures in the world around us, resulting in an attachment style. Right, so I'll spend a bit more time talking about that in the next couple of slides. Next, we have Harry Aponte. So he is the creator of the Person of the Therapist training model, which is an approach to training therapists that takes into account our own life experiences along with our own emotional struggles in order to maximize the ability to use who we are personally in the relationship, in the assessment, in our interventions with our clients. So this model really highlights our signature themes, which are essentially our core issues, our patterns that we see coming up time and time again throughout our lives. So this might be fear of abandonment, this might be rejection, this might be inferiority, et cetera, et cetera. So there are so many different patterns that we often notice in our own personal lives. And the big theme with the Person of the Therapist training model is the ability to make purposeful and intentional use of self when working with our client systems, right? So this is not to be confused with self-disclosure, and I'm going to talk a bit more about that as we move through this. Now, social location is an incredibly important part of this process. So I would like to start this slide with a quote from Harry Aponte. He says, "Within a therapeutic relationship, some of us emphasize differences as marks of distinction, and others emphasize our sameness as signs of essential affinities. Of course, by nature, these polarities are not exclusive of one another, and we can choose to approach them as bridges or barriers to our connections in a relationship. Because for therapists, the relationship is the medium through which we conduct our work." So it's important to start this conversation with the idea of how we as human beings were socialized to approach difference, right? When we encounter difference in our day-to-day lives, do we see it with curiosity, right? Do we see it as a threat? Do we see it with interest? Do we want to understand more? Do we feel the need to avoid and not talk about it? Right? For example, if my client has different religious practices than I do, Do I see that difference in our relationship as something that I'm not supposed to talk about? Or do I see it as an area of my client's life that I can have curiosity about to better understand? Right? Thinking about it in our own personal worlds, a pretty obvious and timely example would be political differences, right? How do we approach difference in religion, in politics, in race, in gender, right? This is an incredibly important area to consider of our lives because we encounter difference every single day. Now, social location refers to the position or placement that we as individuals occupy within a larger societal structure. So it involves various aspects of our identity, right? Such as race, ethnicity, gender identity, socioeconomic status, age, etc. Right? I have them all listed here. This is not an exhaustive list of all of the different identities that can play into social location. Right? Now, the concept of social location acknowledges that individuals and groups experience society differently based on those intersecting identities. Right? It shapes our perspectives, our experiences, our opportunities, and the power and responsibility that we hold as therapists. So it's incredibly important to be aware and investigating our own social location, right? This is the lens through which we look at our clients, how we make meaning of our own life experiences, right? It's especially important for those of us with multiple privileged identities because those identities align with power in some of our bigger systemic structures. So we bear a responsibility to really understand our own biases, our own assumptions, our own reactions to difference, right? Particularly by being socialized in a society and a world that has historically centered white people, cisgender men, able-bodied individuals, and many other identities. And all of these factors influence attachment. So a lot of times in this field, when we talk about culture, when we talk about religion, when we talk about race and ethnicity, it's often spoken about as a barrier to care, as a barrier to getting well or to having good mental health, right? It's this person's parents don't understand mental health or they don't understand addiction or their religious beliefs keep them from getting treatment, right? It's often spoken about as a problem, as an issue, right? Now, this puts our clients in a position of either needing to abandon or defend their culture, at which point, as therapists, we've already lost, right? So if we are going to identify any piece of someone's culture, race, ethnicity, socioeconomic status, religion as a potential risk factor in their treatment, in their therapy, in their life experience, we had better know what the strengths of that person's identity are as well, right? We need to understand how there are protective factors in those same identities because we're not erasing them and we're not trying to get rid of them, right? A lot of times we often have a negativity bias when we think about culture, social location, and everything like that. I'll give an example of this. So my family is mixed English and Irish heritage, right? So generationally, there is a whole bunch of history and baggage that comes with each of these cultures that informs attachment, right? So my English family is a bit more tight-lipped. We don't talk about uncomfortable things because if we don't talk about them, then they don't exist, right? When my family talks about our Irish heritage, it's mostly around cynicism, hard work, and a very rocky relationship with alcohol. Now, there's not inherently anything good, bad, right, or wrong about these different pieces of our life, culture, and history, right? It's just important information to be aware of. And even as I was thinking about this particular slide for this webinar, as I was thinking about my family's experience of an Irish heritage and an English heritage, right? What came to mind immediately for me was all of the different things that made me go, oh, I can see how that played a role in the experience of mental illness, substance use disorder within the generations of my family, right? It took more time to think about the pieces of those cultures that are actually protective factors. It took extra brain work and time and energy to get there, right? So my family with Irish roots loves to gather. They're big storytellers, right? My English family, which is mostly my maternal grandmother, right, is incredibly direct, right? You know exactly where she stands on things. You know exactly what she's thinking, right? Which might not always be pleasant, but I actually find very safe. So investigating and understanding our own social location as therapists is attached to our attachment history and is incredibly important when we think about the power and responsibility that we hold as therapists, right? So as a white cisgender woman in a straight relationship from a middle class background, right? I have my own ideas and understandings about how the world works, about how things should or shouldn't look that live in my subconscious, right? So when I hear little cues or little clues about what's happening, that's for me to go, oh, that's interesting. That's an important piece of information for me, right? It's not something to be afraid of. It's not something to think about and go, uh-oh, that's not great. It's something to say, oh, that's interesting, right? Our ability to be curious about our own experience helps us to model for our clients their ability to understand their own experience, right? So let's get a bit into attachment here, right? Because this is a little bit of the frame through which we are looking at our clients' relationships today. So we've talked about self of the therapist. We've talked about parts of the evolution, the view of self. Now, let's tie some of these different pieces together, right? So a working and evolving understanding of our own attachment patterns is how we can recognize our own role in the therapeutic relationship, right? It's how we're able to discern when something enters the container of space between myself and my client, what's mine and what's theirs? And now, what are we going to do with that? Right? So, in simple terms, I'm not going to get too deep into attachment, right? But I want to give a bit of an overview. So, attachment theory suggests that the way that we bond with our primary caregivers in childhood influences how we relate to other people as adults. And there are four main types of attachment styles, right? So secure attachment means that we feel comfortable with closeness and independence. We generally trust other people, believe that we are worthy of love, have balanced relationships, yada, yada, yada. Anxious attachment means that we worry about our relationships. We fear other people might not love us as much as we love them. We might seek reassurance or be concerned with other people's responses and feelings. Avoidant attachment means we may find hyper independence the most safe, right? We might have some big walls up around us and we're comfortable and safe in our little area in here. I might find it challenging to get close to other people. Disorganized attachment comes from inconsistent or traumatic experiences with caregivers. So we may have mixed feelings about relationships. We might desire closeness, but also fear it. And sometimes these relationships can feel a bit chaotic. So we aren't necessarily stuck with one fixed attachment style. It's not like we get one label at childhood and we're just with that the rest of our lives, right? But we may notice patterns in our own relationships and how our brains and our bodies and our emotions respond to closeness with other people, right? So there are so many different factors that influence attachment, right? A lot of them being what we just talked about on the last slide, right? When we consider different life circumstances, intersecting identities, and generational patterns, it's not necessarily about being prescriptive about what these factors might mean for attachment, but it's the ability to recognize that they may have an influence on a family's ability to form secure attachment bonds, right? So I think we can all fall into those patterns of identifying something that we see as a risk factor and automatically assuming that that translates to insecure attachment, right? So it's important to be very careful of this because when we think about things like economic stability, cultural norms and values, family structure, family dynamics, access to resources, the experience of marginalization, historical and societal factors, right? It's an easy and slippery slope to say that the more marginalized an experience that we have had with our intersecting identities, the less likely we may be to have secure attachment. And that's not true, right? They're all pieces of information that help us to understand what might be a factor in attachment, right? So this is something incredibly important to consider in your own attachment history, as well as our clients. So let me give an example of what this might look like. So this is another quote from Harriet Conte. It says, "The therapist aims to maintain control of the process and therefore the use of self within the clinical relationship. But it is much like paddling a canoe in a stream that has its gentle currents and its wild rapids. The therapist's mastery of the canoe in those waters depends largely on the integration of the therapist's professional skills and mastery of self in the passage towards the therapeutic goal." Right? So, as I mentioned, my mom's side of the family is English and Irish. My dad's side is Irish. So I was recently visiting my mom's mom, this tiny 98-year-old British lady. We're talking about family history, and she looks me dead in the eye and she says, "You know, dear, sometimes in life things happen and it's best to ignore them." And I was like, that is such an interesting way to think about things, right? And I laughed and thought that was just really fascinating coming from her and her life experience. And in the context of how my grandmother was raised, how she raised my mom, right? And what I received as a child, the culture that she grew up in, it makes a lot of sense. It served an important purpose for her. And I can understand that. And think about how this affects attachment, right? Secure attachment means that we can tolerate rupture and repair in relationships. It means that there can be conflict, but we can figure out how to resolve it. We can figure out how to work with it, right? However, if in general your life philosophy is let's ignore things that make us uncomfortable, then that's not necessarily a skill, rupture and repair, that gets passed down, which brings us to my own tendency towards insecure attachment patterns, right? So thinking about my own tendency, I'm using myself as an example here, thinking about my own tendency towards avoidance, right? Meaning that I might pull away or avoid different things in relationships. How might that translate to a therapeutic relationship with a client, right? My ability to respond when there is conflict, when my client has a reaction to me, right? If my client doesn't show up for a session, if there is tension in the room, or as a family therapist, there's tension in relationships in the room in therapy with me, right? That attachment pattern that comes from a whole bunch of different things, right, lives in my brain. It lives in my body, in my emotions. And again, this is not a bad thing. It's just something to be aware of and mindful of. If I feel myself leaning away, getting a little avoidant, right, then that is a cue to me that something underlying might be happening here, might be influencing the way that I am showing up in this therapeutic relationship. Which brings us to the therapist as an attachment base. And I specifically did not say a secure attachment base here, and we'll talk about why. Right? So as a therapist, again, we know we have our own attachment history. We may have overwhelmingly secure attachment relationships. We may have dabbled in a history of anxious attachment relationships. We may have a tendency towards avoidance in relationships, right? We may have a combination of a whole bunch of different patterns. So let me start by saying very clearly that not every single therapist is going to or should have a secure attachment style across the board, right? That feels pretty unrealistic for how we exist as human beings, especially in relationships and how they are the core of connection, livelihood, and well-being. And life comes with all of these different challenging factors that influence relationships. So there is a significant body of research that deep dives into this concept of the therapist as an attachment base, right? So today we're going to focus a bit more on emotional regulation, therapists' own attachment history, and the influence that we might have over our clients and their ability to find attachment relationships outside of the therapy room. So one study found that therapist attachment status, meaning avoidant attachment, anxious attachment, secure, blah, 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 could indirectly affect the therapeutic relationship and outcomes of the clients, right? Meaning our own history of attachment could have an effect on our client's ability to find security in relationships outside of the therapy room. Some of the significant themes are boundaries, rupture and repair, dealing with uncertainty, right? And they also found that the therapist's ability to regulate their own emotions actually acts as a modifier in this relationship, right? So we can have any different type of attachment style and pattern that shows up in our therapeutic relationship. And if we have the ability to recognize and regulate our own emotions, this can act as a buffer to affecting our clients, right? So let's talk a bit about the brain. So first, let's walk through some of the different parts of the brain. I'm not going to get too deep into this for the sake of time. I see we're almost at 11 already. But the first part of the brain that is formed is the brainstem, right? This is often called the reptile brain, right? This is the part of our brain that is concerned with all of our body functions that we often don't think about, right? This is the part of our brain that is concerned with, am I safe, and a human being's survival. Our limbic system is the emotional center of the brain, right? So this is where our fear center is. This is where our reward center is. This is where our fight, flight, freeze, and fawn responses live, right? This is the part of the brain that is also concerned with, am I loved, right? This is a lot of where attachment lives, right? So this is often who we become when we are triggered by something. Important to remember. Now, the last part of the brain is the cortex, right? This is the last part of our brains to develop. And typically we say it develops fully in mid-20s, though there's actually research that's saying it's more towards our 30s, right? It might be like 28 years old, right? So this is the part of the brain that thinks in the long term. So it understands our goals, it aligns with our personalities, our morals, our values, right? It's able to think in complex terms and understands nuance. So if you are particularly keen on CBT, right, cognitive behavioral therapy, this is the part of the brain that you are speaking to when you're using CBT, because it is clear, it is rational, it's logical, and can be focused. So the way that these parts of the brain talk to each other can be overloaded by trauma, right? It can impact the relationship between the cortex and the limbic system and really sensitize the limbic system response, right? So again, you can think about the limbic system as asking the question, am I loved? And the brainstem as asking the question, am I safe? Right? So let's relate this to attachment. So attachment insecurity, right? With attachment anxiety or avoidance, getting triggered translates to the limbic system, right? This is what turns online. Now, remember, this is the emotional center of the brain. So when our limbic system is activated, there is decreased activity in the cortex, right? So we have a decreased ability to think clearly, think rationally, regulate our emotions. And the part of our brain that is most concerned with big feelings is lit up, it is online, it is often running the show, right? So this relates to both us as therapists and our clients. So if we're able to regulate our emotions as therapists, we can get back to the cortex and see our limbic system response from a more clear perspective. Now, attachment style can influence the way that our emotional regulation functions within our brains. So, right, those of us who have some patterns of anxious attachment or avoidant attachment, right, we can become highly emotional when threatened with social rejection or relationship loss, specifically for anxious attachment styles, right? So when there is some cue to our brains that there is a threat of a relationship loss, whether it is with people in our personal lives or a client or a client system, right? When we're threatened with rejection or abandonment, that activates our own limbic system, right? That activates our own experience of attachment anxiety, right? Now, those of us who have more avoidant attachment patterns, right, who tend to distance ourselves or disengage from emotional situations when this part gets turned online, right? So when something happens in the therapeutic relationship and our limbic system gets turned online, sometimes we have the ability to move in or move out, depending on our own history of relationships, right? So again, our own attachment stuff interacts with our clients, right? But thinking back to the last slide, we know that emotional regulation can act as a buffer here, right? Which is why we are talking so much about awareness and self. We're spending the first entire hour talking about ourselves as therapists for this reason. So let me give an example of this. I am sitting there with my client, Sally, right? She is describing a relationship with her mom. Now, I have a history of an anxious attachment style with my own mother, right? So Sally is describing the different things that her mom has been doing in the relationship, right? She's really talking crap about mom here, right? She's going on a tangent. She's waiting for me to validate her experience and co-sign whatever position she's taking within the relationship. So in my trained therapist cortex, I might know intellectually, you, Sally, are trying to differentiate from your mom right now. And the way that you are showing up in this relationship is actually really reminiscent of your teenage years. And right now, you're in your late 20s. So I actually need to do a little bit of therapeutic challenging to help you see your part in this and soften your lens of your mom. But my own attachment cues are getting triggered, right? So my attachment anxiety is starting to turn my limbic system online because something that she's describing feels familiar to me, right? So again, those of us with some anxious attachment patterns, right? If we are threatened with rejection or abandonment, then I might be less likely to challenge this client in regards to her relationship with her mom. I may be more likely to co-sign, right, to agree with the way that she's interacting with her mom right now out of fear that she might reject me if I challenge her. Which in my therapist cortex, I understand that healthy challenging is a hugely important part of the therapeutic relationship. But in my limbic system, my part of my brain that is going back to my own relationship with my own mother is online and it's worried about abandonment, right? So my response might be something like, yeah, your mom sounds like she's acting really weird in the relationship. You should set some boundaries with her. Now pause. The word boundaries can sometimes be a red flag to us. And this is not to say anything bad about boundaries. I love boundaries. And sometimes the word boundaries can function as a band-aid for us as therapists that we offer to our clients when their relationship with someone else in their life is making us uncomfortable, right? If there's something about that relationship that I'm seeing that brings up something in me, without exploring what's actually happening there, I might just throw out the word boundaries as sort of a placeholder until I can re-regulate. Now, if I'm able to use my skills in that moment to get myself back to my cortex, I may say something to Sally like, I'm curious if you'd tell me more about your role in this conversation, or what might be happening for mom that brings her to operate this way, right? Help her try and build some sense of curiosity and compassion around mom, right? So there's a whole lot of work that happens in real time as we are working with our clients and our own stuff is getting activated, right? Our own limbic system is getting turned online based on what we are observing in our clients. So all of that being said, right? We don't need to be embarrassed by our normal human reactions, right? Let me take a pause here because I don't want for those of us to be sitting here today listening to me talk about attachment, the brain, emotional regulation, to sit here thinking, oh boy, I am chock full of insecure, avoidant, disorganized attachment patterns. So does that make me a bad therapist? Because no, it does not. Our humanity, right? All of our nuances, of our worlds, of our relationships, are actually what make us good therapists, particularly when we're able to regulate our own emotions. Right? So this is where we want to get more specific about a purposeful use of self, right? Which is typically most effective when we have awareness of our own relational patterns, right? Now, I want to be clear that the purposeful use of self does not mean self-disclosure, right? Those are two distinctly different things, right? Self-disclosure is a whole other topic here. Use of self is about how in touch we are with our own thoughts, our emotions, our physiological reactions, our generational stories, right? These different pieces that make us human beings and that bring us into this field in the first place. Right now, we all have our own philosophies about how much our stuff comes into the therapeutic relationship with us. Right? It comes with us when we sit down and we open up a Zoom meeting or we sit across from a client. Right? Now, I am not here to evangelize one way as operating as a therapist. I'm here to advocate for continual self-reflection and growth in the self of the therapist. So let me give an example of a purposeful use of self. Right? So you are sitting with a client and you are having a conversation about something in their life that brings up for you an experience, a memory, a big emotion, something from your own life. Normal human response, right? We're human beings. We bring with us all of our stuff into our therapy sessions. Now, in this moment, you find yourself wanting to let this client into your own world by talking about it in some way. Pause. Now ask yourself in this moment, for what purpose would I be sharing this? What is the insight that I want my client to gather through this self-disclosure? Right? Often it's because we're trying to make a connection. We're trying to build a bridge between our two experiences. And as the therapist in the room, in the position of power and responsibility in this relationship, we are the ones that need to do the work to discern what is happening internally. For instance, am I slipping down into my limbic system and my emotions are becoming bigger and I'm getting brought back to this memory for myself? Or am I able to regulate myself and use my clear, rational cortex to draw a distinctive line between my own experience and my client's? Right? So let me give an example of this. A colleague was recently telling me about a client system that she's working with. Right? This couple identify as Orthodox Jewish, and her religious background is in evangelical Christianity that she has since pivoted away from. Now, she has this client who is now pivoting away from how they were raised. Even though we are talking about two distinctly different religions, there are similarities in this. She said to me, I don't know a lot about Orthodox Judaism, but I do know about moving away from a clearly defined worldview. That I am familiar with. So in session, she isn't sharing about her experience of fundamentalist Christianity, but she is able to relate to the unsettled feeling and the shaky ground of moving away from it. That is the shared experience. The fear, the disloyalty, the ruptured relationships, the disrespect, the worry, those pieces make up the bridge of humanity between the therapist and her clients. So as they're talking about this experience, she might ask, are there people in your life that worry about your change? She is using her experience of her family being worried to be curious about their experience, right? So the different life experiences that we have had is really about the use of self and recognizing how our own experiences have themes that then help us identify bridges of humanity to our clients, which requires us to do the work in our own brains through reflection and regulation, right? So this is a pause where I want to take a break, right? Because I've been talking for a long time here. So we are going to move into, after this 5-minute break, oops, we're going to move into talking more about clients' relationships. And then third part is integration of these two, right? So this first hour was a lot about self, but I'm going to take a pause for 5 minutes. So for me, it's 11:06 right now. We'll come back around like 11. Right. I am going to keep going in the interest of time, and um, towards the end, I will answer some questions. And you're going to see my cat here. So now let's talk a bit about context before I move into relationships. Right. So as we walk through these different topics together, it's important to place ourselves in our own specific context in the role of therapist, recovery support specialist, recovery coach, right? Because the role that we play will actually kind of vary throughout these different contexts, right? Because the acuity and the needs of our clients tend to be different based on these levels of care, right? So, for example, in general outpatient programs, 1 hour, 1 day a week, I might be using internal family systems to unburden parts and reorganize my client's inner world. In residential treatment, I will be focused on building skills, discharge planning for the next level of care, supporting my client's family and getting connected, right? In IOP, I may be supporting my client in using their skills to regulate while they're doing trauma therapy, right? As therapists, we are sometimes working in multiple different levels of care, right? At one point in time, I was in residential treatment, doing family work, and in general outpatient, doing individual trauma work, right? So sometimes we are transitioning from being an IOP therapist to a GOP therapist, or from blah, 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 right? Working in these different levels of care have different implications for what we are faced with in our clients. So a couple of considerations that I want to highlight for everyone to be mindful of are the length of time we'll be working with clients, right? So this might be 10 days, 30 days, 6 weeks, 6 years, right? This depends on a whole bunch of different things. Now, another consideration is how the level of care informs the acuity of our clients, right? So this pertains to self-harm, suicidality, the nature of substance use, the skills to regulate their emotions, protective factors, support systems, right? So the higher the acuity and the sense of crisis, the more safe it is to have a structure, consistent and predictable therapeutic environment, right? So the more trauma that our clients have, the more likely their brains are attuned to the changes within the environment. And when we are their environment, our clients can be incredibly attuned to us, right? So this is where level of care is incredibly important in thinking about the self of the therapist, right? Because if I work in residential treatment, I may see my clients every single day of the week. If I work in outpatient, general outpatient, I may see my clients weekly or biweekly. So there are going to be different attachment cues that might alert our brain system, right? That the acuity of behaviors, it might be romantic relationships or sexualized behaviors in a residential treatment setting. It might be various family reactions and behaviors, or the need for structure and focus within the session, right? Our own feeling like we need to rescue our clients from the reality of their own lives, right? There is a level of directness that is required at higher levels of care. And this may interact with your own attachment needs and theoretical orientation, right? So if you have a therapeutic relationship that is theoretically going to last longer, then finding out how that relationship works will be more important, right? Than at a residential or a PHP level of care where it's more of a temporary relationship, right? So just some things to consider when you're thinking about the level of care where you work and how your own attachment style and history interacts with the typical behaviors that naturally come with higher levels of care or lower levels of care. So let's talk about relationships. So let's first talk about why relational worlds for our clients are important, right? So we can call this a number of things. We can call it our client's relational world. We can call it relational capital, right? It's all the same. Healthy connections with others have been consistently linked to improved mental and physical health outcomes. Right. So when people come into therapy, they're often wanting to change a certain behavior or a set of behaviors. They are wanting to better understand themselves. They might want to improve a relationship. They're wanting to be able to better function in their day-to-day lives. They might want to resolve trauma, right? There are a number of reasons why someone might come into therapy. So when someone is wanting to make changes in their life, whether that is mental health, physical health, relationships, regulation, right? We as therapists meet them where they're at. So change often occurs most effectively when we have secure relationships, because these relationships provide a strong foundation of support and stability, right? This kind of comes back to the idea that the point of getting a therapist is to not need them anymore, right? It's a funny business model we're all in, right? Relationships offer emotional support, which reduces anxiety and stress, especially as we're trying to take a risk of making changes in life. It makes it easier to, again, take risks, adapt to change. Relationships offer feedback, they offer guidance involving honest and constructive conversations, which is incredibly important. When we feel secure and supported, we are more resilient in the face of change and challenge. Relationships also offer a sense of belonging, which is right in the middle of Maslow's hierarchy of needs. Right? We are human beings. We need to feel connected to other people in order to survive, right? And to not only survive, but also thrive in our lives. People share resources such as time, energy, practical support, right? Supportive relationships also encourage personal growth and self-improvement. So all in all, relationships can act as a safety net, right? Providing the environment that is required to learn and grow as our clients make changes that they come into therapy to understand and to enact. So clients exist in a much bigger context than how we're just able to see them sitting right in front of someone. I really appreciate using the Bronfenbrenner ecological model, which is this little wheel we see here, as a way of seeing our clients in the bigger context of their lives and relationships, right? So this is a little bit stemming from the social location conversation about how we as human beings, as therapists, exist in a much bigger context that influences all of the different parts of our brains, bodies, reactions. Same with our clients. Right? We might be sitting directly in front of someone and you might just see me, little human being right here, right? But it is incredibly important that as a therapist, we can zoom out and get a bigger picture of what the world around you looks like and all of the relationships in that world, right? What we are working with as therapists touches so many other people, systems, structures, social influence, right? We're talking about work, school, neighborhood, extended family, social media, political systems, culture, development, right? And we know that the opposite of illness, mental illness, substance use, right? Physical health, chronic illness, is connection. Connection to different systems around them, right? Connection to self, connection to other people, right? So it is incredibly important that as therapists, we are asking questions about these different systems that surround our clients, because this is the context in which our clients are trying to make the changes that they come into therapy trying to make, right? These are the people, these are the different social structures, environments that they are leaving our offices to go out back into and try and take the risk of doing something different, right? Which can be incredibly scary and hard because homeostasis is a real thing, right? So this is just mostly a plug for a systemic approach to understanding human beings. Now, first, we were talking about our own ability to regulate our emotions as therapists. Now let's talk about our clients' ability to regulate their emotions. So many of the different behaviors that our clients come into therapy wanting to change can be traced back to a big limbic system or brainstem response, right? That our clients then found a solution to be able to manage, right? So this little graph here sort of follows through how that works, right? Solutions may be using alcohol to dull the physiological response of a trigger, restricting our eating to make ourselves smaller in the world, diving into video games to escape reality, self-harm to feel something from numbness, overworking, yelling at someone to get them to back off of you, isolation, etc. Right? There is an actor who has a quote that I really love. He says, "Drugs and alcohol are not my problem. Reality is my problem. Drugs and alcohol are my solution to my problem." Right? So different behaviors, again, that our clients come into therapy wanting to understand or change are solutions that they have found to different experiences in life that show up in their brains, bodies, emotions that feel really hard. Right? So we have, I don't know if you can see my cursor, but we have under extreme emotions, all of these different examples of emotional, physiological reactions. And then the ways that we have found to manage that. Because in that moment, our brain might not have known a better option. So when we are triggered by something, it comes in through the brainstem. And if it is familiar to our brains in any way, it will often elicit a big response in our brains, in our bodies, such as sadness, anger, shame, right? And this is matched with a physiological response, such as your heart racing, a knot in your stomach, right? Your head feeling kind of blurry, your body language kind of sunken and down. And again, as human beings, we find all sorts of ways of managing these feelings, right? Which is why it is incredibly important to pay attention to our clients' relationships, because relationships are regulating, right? I know as therapists, we are all going to be sitting here thinking, wait a second, relationships might also be triggering, right? And yes, that is also true, because other people are mirrors that reflect back to us all different types of things, including things that we might not like the looks of, right? So when other people are mirroring things back to us that make us uncomfortable, it can make us go, that person triggered me. That person is triggering, right? It's easy to say, that is the thing that made me feel this way, that made me feel this way. So part of our work as therapists is to help our clients understand what about the relationship is reflecting something back that they don't like, and what part of that relationship keeps them coming back to it. And we will get more into that in the next part of this webinar here. However, this slide is really to deepen our understanding of how and why relationships can and are regulating through a scientific lens. So to dip a toe in neurobiology, let's talk about the neurobiological basis of attachment. So early attachment experiences actually influence the development of structures of the brain that are involved in emotional regulation, such as the amygdala, which is part of the limbic system, and the prefrontal cortex. These parts of the brain are critical for processing emotions, forming relationships, and attachment experiences also regulate our neurochemical systems, including oxytocin and dopamine, which play significant roles in bonding and reward processing, thus affecting our social behavior and attachment patterns. Now, oxytocin is also known very cutely as the cuddle hormone, and it is a connection hormone that increases with any sort of mutually respectful touch, such as holding hands, hugging, and generally feeling connected to other people. Dopamine, also known as the happy hormone, results in feelings of general well-being. Now, this is a primary driver of our brain's reward system, which again lives in that limbic system. And it floods our bodies when we experience something pleasurable. Now, when it comes to the long-term effects of brain functioning, secure attachment relationships buffer against stress by regulating neural responses in the brain areas involved in threat processing. So essentially, the more relationships that our clients have that resemble secure attachment patterns, the more protected they are against other triggering things in their lives that their brains perceive as a threat, right? So when we experience different triggers in our day-to-day lives, the more relational support and capital we have, the less our brains will react to those triggers. The less we will feel those big emotional physiological responses that bring us to substance use, suicidality, self-harm, yelling, isolation, all of those behaviors that human beings find to manage themselves. So the buffering hypothesis is a concept in psychology and stress research that says our social supports act as a buffer or a protective factor against the negative effects of stress on the brain. Right? So I'm going to skip through some of this in the sake of time, but cognitive regulation and identity and self-esteem are incredibly important in relationships as well, because again, people are mirrors back to us that help us as human beings find a sense of self. And the stronger a sense of self that we have, the more protected we are against the challenges of life, the stress of life, and different triggers that we might have. So as therapists, we are going to walk through, in the next 30 minutes here, a couple of self-checks, right? Ways that we can check ourselves for any different subconscious cues of attachment that might be kind of slipping through that we want to be aware of so that we can make purposeful use of rather than letting our big emotions and our history kind of run the show. So the first is documentation, right? When we come right out of a therapy session, right, that is when we are most fresh. That is when our brain is really processing everything that's going on. Our emotions are still kind of online and intact. So if I sit down right after a session and write my note, and then I wait 24 hours and I look back on it, I'm going to likely know how I felt about that session, if I was dysregulated in it, or if my limbic system went online during it. It gives us, again, this is not to say, uh-oh, check your documentation because you might be triggered and you might be able to see it. This is to say that it gives us a lot of helpful information to read back what we write about our clients. If you're someone who takes notes in session, right, whatever we write down, reading that back can help us to say, was I feeling something about this? Was I making a judgment about my client here? What did I pick up on that I found was important? So we're going to give an example here. For context, this is an individual session note from the residential level of care, right? That has been adapted for client privacy. The client was on time and present for the session. The client and therapist reviewed and updated treatment plans. The client declined outcome assessments at this time and was given a printout to return. The client and therapist discuss aftercare. The client wants dog to come with her. Therapist told the client this could limit options. The client and therapist discuss differences between ESA and service animal. The client reported having stomach aches that sent her to the ER earlier this week. The client reported having back aches from cooking all the time. The therapist educated the client on distress tolerance skills that can help with the pain. The therapist suggested the client, I lost myself here, set boundaries, and to only cook when it is her turn. The client reported they only eat grilled cheeses if I don't cook. The therapist told the client to let them and take care of your needs. The client will try and set boundaries and use skills for pain. The client and therapist discussed abandonment by mom. Don't know where that last sentence came from. Now, everyone check in with yourself after having read this note. Right? Everyone think about what it is that your first impression of this note is. Right? What feeling did you get? Check in with your body. Right? Do you feel an emotion showing up, a curiosity, a judgment? Right? Or do you feel pretty neutral? Are you curious, confused, impressed? Now, what do you think that this therapist felt towards this client? Now, here's what I am reading between the lines. We talked treatment plan, we discussed aftercare. Therapist was like, you can't bring the dog with you. Client was like, why not? Well, let me tell you what the rules are. Client tries to connect her mental and her physical health with stomach ache and back pains. Therapist is like, here's how you tolerate that. Therapist is like, stop being codependent. And then we take a huge left turn into mom's abandonment, and that's it. I get the feeling that this therapist is kind of annoyed by this client and is trying to rush them out of there. Now, if we look at this from a technical perspective, therapist checks the boxes. Aftercare, skills, direct quotes from clients, treatment plan, intervention, plan moving forward. However, I can almost feel the therapist rolling their eyes at the client through this screen. Now, again, this is not to judge this therapist. This is to say, wow, we are humans. We feel things, and our writing tells us what we feel. So as therapists, and again, therapists meaning recovery coach, recovery support person, whoever, writing our emails, if we send a text, right, our own notes, whatever we write is a really good indication of our own reaction to what's happening, right? So that is really helpful information for us as therapists as we move through the treatment process with our clients. So use this as a way to check yourself to say, let me check in with how I'm feeling about this client or the session that we just had or the stuff that they're bringing into session. Now, let's talk about cultural strengths in relationships. Now, again, for the sake of time, I don't want to spend so much time on this because we already talked a bit about how culture is often viewed as a barrier, is often viewed as something that's going to prevent a client from getting their needs met or getting to the next level of care, right? So there are so many ways that being able to highlight and identify cultural strengths in relationships can be protective factors for our clients. Research shows that a higher degree of social integration is associated with a lower risk of dysregulation, both early and late in life. And conversely, lack of social connections are associated with higher risks during different life stages. For example, social isolation increases the risk of inflammation in the body in the same way that physical inactivity does during adolescence. In older age, social isolation has a similar impact on hypertension, right? So being able to focus our energy and our curiosity on our clients' experience of culture helps to connect them to something bigger than themselves, which again is a huge protective factor that buffers against stress, hardship, and adversity in life. Right? So let me give an example. I've been working with an Italian family for a long time, and they've been really struggling to connect with one another because their oldest son is constantly in and out of crisis. Right? So they have a hard time seeing the strengths in their family. They have a hard time seeing what is working and going well in their family system. So as we're talking, I'm asking what is the moments where you spend the most time together, just practically? The mom's like, cooking dinner. Like, okay. So tell me about your experience of food, dinner. Like, what's the significance of this? She's like, well, we all love eating together, right? We use a bunch of recipes that I got from my mom, who moved here from Italy, right? It's a huge part of our day-to-day life, but we're all just kind of miserable while we do it. So the process of our treatment with this family became about connecting them to their Italian heritage and the different spices that they're using, the different recipes that they're cooking, and the way that their brains are able to orient to positivity and strength happening in their family, which then acted as a buffer to support them in managing the stress of their eldest son's mental health crisis, right? So in the beginning, it might feel like, why are we talking about this, right? But it offers so much support in connecting people to something bigger when their worlds feel really small and scary. So let's move on to our next self-check here. I recognize I'm rushing through these because I'm trying to get to everything here. Supervision, peer support, and case consultation, right? So our own words and feelings are incredibly important. We already know this because how you hear yourself talking about your clients gives you a lot of information about how you feel towards your clients, right? So there are different ways that we can tap into ourselves through both process and content. Right? Process being the underlying dynamics through which the therapeutic work occurs, right? It's how the therapy is conducted, the interaction between therapist and client, right? So the content is more the material that we're working with, right? So being able to recognize in supervision when you're talking with people, when you're having casual conversations with your peers, right? If I go to one of my colleagues and I say, oh, Gwen is so codependent with her mom, right? That tells me, oh boy, that is lighting up my limbic system because that is touching on my own attachment patterns and I'm making a judgment about their relationship. If I'm able to say, Gwen has some rescuing tendencies with her mom that make sense and they're not working for her anymore. That's a very different way of talking about things. Being able to go to other people in your work, in your life, who are able to be honest with you and give you constructive feedback is incredibly important, right? Because if I go to a colleague and I am talking all types of crap about one of my clients, and she's able to pause and say, have you thought about what's happening for you in this moment? Then I'm going to go, oh, okay. That is a humbling moment and an incredibly important one, right? If I have a colleague who's going to go, yeah, that client sounds really obnoxious and really terrible, right? Then that's actually not helpful for me. And it's definitely not helpful for my client. right? So sometimes, again, we are human beings. Sometimes we talk badly about other people, right? We're not going to sit here and pretend like none of us have ever talked crap about a client, right? And when we do, those are really helpful moments, not to be embarrassed by or ashamed by, but to say, wow, that gave me a lot of insight into what is happening inside of me that's reacting to my client this way. And I actually really need to be aware of that and do some work investigating that and being curious about it, because that will inform how I show up to my next session with my client. So, in the same process that we follow for our clients of helping them to recognize what's going on, helping them to regulate, and helping them to respond to their environment, let's talk about how we integrate this, right? So, as therapists working actively with clients, and again, when I say therapists, I mean anybody who works with human beings, right? You might be sitting here thinking to yourself, all right, this is all great and everything, but what do I do with this information, right? In session and outside of session, there are different ways that we can stay attuned to our own attachment cues. So let's talk about them. So first things first is our initial reaction, right? Our client says something, tells a certain story, calls us a million times on the phone, right? Doesn't show up for a session or talks nonstop in a session, right? Then the brain takes in this information through the brainstem up to the limbic system, and it arrives at the cortex. Now, again, if this information coming into our brains resembles any attachment trigger that we have in our history or current relationships, a red flag in the brain might be raised. And for the sake of the conversation today, we have the anxious response and the avoidant response, right? So we can think about this as leaning in or leaning out. There's a lot more nuance to this story, and that could probably be an entire other webinar. But how we can think about this is, does this information bring us closer to or farther away from the client? For example, I remember early on in the days of being a therapist, I think this was one of my very first clients actually. One of them did not show up to one of our sessions, and I already did not feel like I was doing a great job, right? She was a no call, no show. I texted her, I called her, right? I mean, I essentially had to stop myself from showing up at her door because I was so anxious. I think I called one of my other therapists in training friends and went down a spiral about how I'm never going to be a good therapist. I don't know why I took this job. I don't know why I did this training, blah, 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 blah. Right? Now, of course, this is fairly dramatic, right? But the point here is that my initial reaction was anxiety, fear, abandonment, rejection, right? Those were the first feelings that came into my body in reaction to this client missing our session. Now, as I talked with people in my life, that information slowly made its way up to the cortex, and I could rationally understand that any number of things might be happening in this situation. And what ended up happening was the next day, she texted me saying that she was in class and she thought our session was the next day. So, that was humbling. But this experience was incredibly important information for me to understand. Ooh, that was a big reaction that I had. And it was as if I was not present during it either, right? I felt myself texting and I was like, I probably shouldn't be doing this. Like, this is the third time I've texted her, right? But it just happens. It comes out when we are triggered. And looking back on that, I can say, "Oh, babe, that was a hard moment for you and an important learning lesson in what my dysregulated response is to any semblance of rejection or abandonment." Right? So think back to different moments with clients where you have felt a big reaction, right? Because again, it's not something to be embarrassed about or to tuck away and hide and never talk about again because I'm sharing it with about a bunch of hundred of you, right? It's something to say, this is important. This gave me information about myself that I need to know. Now, the same way that our clients need people, we need people. As therapists, it can be an incredibly isolating job, right? You sit with someone, you write your note, you sit with someone, you write your note, you get home at the end of the day, and you're like, all right, now I guess I got to talk to the people in my life, even though I just spent all this emotional energy being present with all these other people, right? It can be an incredibly isolating experience and use a lot of our attunement and energy, especially for people who might be more introverted, right? I recently really came to terms with the fact that I'm very extroverted, right? And I still get home at the end of the day and I'm like, ooh, I do not want to have this conversation with my boyfriend right now. I'm tired. So as therapists, we need other people to be able to share our raw, vulnerable experiences with, right? To be able to hold us in these feelings that we get. Because I know in therapy training, they're like, don't feel what your client feels, or like, don't take on your client stuff, or don't work harder than your clients. But if we're being honest, we feel what our clients feel a lot of the time. And again, that's not a bad thing, right? And how do we use our own support systems to be able to regulate, to be cared for, to have coworkers and people in our lives to humble us and to check us and to say, Gwen, I think this might be more about you than it is about this family that you're working with. And for me to say, yeah, you're right. Ooh, I got to go to supervision about that. I have to think about that. I have to I have to do whatever I need to about that. Now, another self-check is different cues that tell us where we are in our brains, right? So these are just a whole bunch of different examples of this, right? So if I am looking at my physical experience, right? If I am deeply breathing from my belly, right? If my shoulders are coming up, if my heart's racing, those are cues to me where I am in my brain. If I'm sitting in my emotional center of my brain, if I am in survival, right? Or if I'm calmly sitting there listening. Discernment, if I'm able to kind of recognize what's mine, what someone else's. If I'm curious, if I'm worried, or if I'm panicked, right? These are different examples that help us understand where we are in our brains. And again, I am not going to sit here and say that we're all going to sit in our cortex all the time. There are times when we get into full dysregulation in our client experiences. I am working with a 15-year-old girl who came in for disordered eating. She recently, this was about a year ago. So recently she was sharing with me that she tried alcohol with her friends for the first time. And boy, was I freaked out, right? She kind of led up to it like, oh, I don't know if I'm going to tell you this. I'm a little, she was nervous, right? She didn't know what she's able to tell me or not. And I felt my heart racing, a pit in my stomach. I was so close to being like, don't do that, don't do that, don't do that, don't drink alcohol, right? Because I remember being 15 years old and having a real adolescent rocky relationship with substances, right? Those became my solution when I was her age. So sitting in front of me, mirroring back to me my own experience brought back a lot of stuff, right? I felt myself, I had to just sit there and be like, don't do anything, don't say anything, right? So I had to figure out something to keep the conversation going while I re-regulated myself. So it's like, tell me more about that. Meanwhile, I'm trying to take my deep breaths, I am trying to re-regulate because I am about to tell her that this is bad, wrong, scary, all the risks of drinking alcohol, all the risks of tolerance and dependence, blah, 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 which was not helpful for her in that moment. So being in touch with all of those different experiences was incredibly necessary in that moment. And again, those big cues and symptoms are going to happen for us as therapists. And I recognized mine. I was like, "Ooh, this pit of the stomach means I'm about to say something that is probably not helpful for her, or that might make her feel judged, or make her feel like she can't tell me these things anymore. So I need to take care of myself in this moment before I give her any type of intervention or feedback or anything." Right? Sometimes it's a deep breath. Sometimes it is a glass of ice water, right? We'll get more to the skills in this in the next couple slides. But again, these are just some examples. I would highly encourage everyone to take inventory for themselves, right? What are the different categories of cues that help you know that you are slipping down in your brain in session? Because I guarantee you've got at least a couple of them. We all do. This is a really wonderful quote about being attached to, connected to our bodies. All right, so if we are cut off from our bodies, we are cut off from a large source of information. Information coming from our heads is often limited by thoughts and theories that interfere with a more direct perception of what is going on. When we are attuned to our bodies, we are more aware of nonverbal communication that underlies the words we are hearing. Now, let's talk about some regulation skills. So, I'm not going to go through every single one of these, right? But there are many different ways as therapists that in session, we can help ourselves to regulate, that we can take care of our own attachment cues that are being lit up in our limbic system, right? And if you look through these are many of the same skills that we teach our clients in helping their nervous systems to re-regulate, right? So you can see how this is a parallel process. Our clients being able to watch us re-regulate is incredibly empowering and important and valuable, right? Our clients watching us model what it's like to have a human response and then care for ourselves is why humans will always be doing this therapy job, right? Because it helps them to feel like I'm not alone. And sometimes my nervous system takes over and I'm down in my brain and I'm freaking out because my therapist does it too. So the last slide, I recognize I'm getting to the end here, are some different ways of having relationally supportive conversations, right? So on the left over here, those are some different examples I've already talked through. On the right, in session, when your client is talking about a relationship, right? And you feel yourself either going to like, ooh, that's really unhealthy, or like, ooh, that's a really healthy relationship, right? Some ways of getting more nuanced about it are to talk about the protective factors and the risk factors within that relationship. All different types of relationship, right? Let's think back to my client, Sally. She's sitting there telling me all of these horrible things that her mom did. When I'm able to say, why do you think mom did that? What do you think was happening for her? That was the first time that she had ever thought to think about that, to actually ask those questions, right? I was able to model for her what was going on for mom that day. Is that typical? Where do you think that reaction comes from? Then it brings our clients to get outside of their own echo chamber and look around them and understand what happens for other people while still being validated in their own reaction to it. The strengths within the relationship, communication skills, right? If someone is really zoomed in and the world feels very small and scary, helping to zoom out to bigger systems. Cultural influences, societal influences, generational patterns, right? All of these different variables are at play when we are in relationship with other people. And if it feels narrow and focused and scary and big, let's pause and zoom out. So I recognize we're running out of time here. So this is all to say, befriend your attachment patterns to best support your client's ability to heal through connection, because we are our best tools. We are our best ability to create a container for our clients to work out their stuff in. So thank you, everybody, for being with me in these 2 hours and listening to me talk about this. I really care about this subject. So I will turn over to Callie for a couple minutes, I think, and then we'll answer some questions. Callie, if that's the program.
Sure. I just want to remind everyone that the evals for CEs will come out in the next couple hours. Just need to go through our list here. Again, you can only miss up to 10 minutes to receive credit, and then you'll have until next Friday to complete the eval. So make sure you get that done next week. Gwen, great job. I thought that was an excellent training. It's so interesting and also often annoying how everyone can be a mirror to us. So thank you for that. I had texted you a few of those questions that came through. And then also I made notes of any resources that you mentioned. So next week, everyone will receive the recording, the resources that Gwen mentioned, and then some of those key slides and some notes of what she was talking about. So you'll get a pretty thorough explanation there, as well as the information for our next webinar, which is September 27th. So you can take over those questions, Gwen.
Thank you. Also, if anyone is interested in any of the references that I used for all this information, please just email me and I can send you some of those. So first question is, you said that it is neither right nor wrong to have a therapeutic identity that is separate from our personal identity. However, shouldn't we modify our therapeutic identity based on what the client needs and not our own personal preference? Great question. For example, just based off my own personal preferences, I would not want to engage the services of a therapist who was too boundaried. It would be hard for me to trust that type of therapist or to relax. However, conversely, I know that someone who really values authenticity and not having a different therapeutic identity, sometimes need to be more boundaried, professional, emotionally restrained. Right. So this is a really great question, is like how we move ourselves based on the client needs or how we perceive our client needs. And I think this has a lot to do also with the level of care where we work, right? Because if we're at a higher level of care, a residential level of care, or a PHP or an IOP, right, there are specific needs that are being met through the therapeutic relationship that are attuning to the higher acuity of our clients, right? So it might be less about a long-term relationship and like who's a good fit for who. It might just be about how do I attune to my client's needs while staying sturdy in who I know myself to be as a therapist, which is a really important balance. Now, if we are working in a longer term therapy, right? If we are developing a relationship where we're going to do trauma resolution, where we might be working together for years, right? Then finding a good therapeutic fit is incredibly important. And I'm the first to say, I'm not going to be everybody's therapist, because if I moved myself based on what a client needed, then I'm not being true to who I am and how I operate. And my interventions, right, my reflections, my ability to attune to that client is going to be a little wonky or wishy-washy, which the client then feels and ultimately often doesn't feel very safe. If I am consistent and sturdy and myself, right, then that creates a sense of safety for my client. We're not always going to align on everything, or what I might offer might not always be what my client needs. But is there enough of it that makes it a valuable process of therapy and therapeutic relationship? Right. So that was a bit of a lengthy response, but I think the more that we move ourselves as therapists based on what we perceive our client needs, right, with being boundaried or, self-disclosure or different things like that, the more vulnerable we are to trying to, well, first of all, it'll also be exhausting, because if it's coming out of our inauthenticity, then it just gets like it takes up a lot of emotional energy, right? And if it's inauthentic to who we are as therapists, then our clients are going to attune to that and not feel safe, right? So another question is CBT less effective with people younger than mid to late 20s? I don't think CBT is less effective. I think it's a really helpful tool for people who are actively baking their cortex, right? Because if you think about people up until age like 26, 27, 28, your cortex and your logic, your clarity, your reasoning, that's all baking in the moment, right? That's all being formed. So using CBT is a really helpful tool of really getting clear and intentional about what exactly is being baked there. Right now, if you have younger adults or adolescents who have big emotional responses, who might not have the tools to soothe their nervous systems or to help their brain to regulate, then those regulation, more like DBT skills, might also be incredibly important for that. Three questions here. How do you approach cultures that avoid any expression of feelings, are very performance-oriented, and condone aggression towards women in marriages? So what I want to start with here is we need to respect clients' ability to choose the life that they're going to live, right? To live within their bounds that they consider for themselves. Right now, when it comes to issues of safety, right, we can certainly support our clients in understanding the risk factors associated with that, and what are the protective factors of those relationships as well. What is serving a purpose for a client in that relationship that keeps them going back to it? Right? What keeps them connected to that relationship? And is that a need that can only be met in that relationship, or is that a need that can be met in another relationship? Right? Now, cultures that typically avoid expression of feelings, right? There are different languages that we can speak with our clients, right? Some people speak a very intellectual, thought-based language. Some people speak a very emotional language. Some people speak a very physiological language, right? I would want to understand what language that culture and that client speak, what they are most comfortable with, right? And if they want to express emotions, right? Some people might be like, I'm good. I don't really need that. This is a part of my life that I am comfortable with. And if I want to make these changes that I can do without that part of my life, then okay. I'm not here to tell people that they have to do anything because it's the right therapy thing to do. I'm here to help my client live in the reality of their own life in a way that is safe, that offers growth, and that meets their own goals. I've heard other therapists say they received this training, don't work harder than your clients. I haven't encountered that. Where does that stem from? So the don't work harder than your clients thing is it's a very interesting conversation because I think it can be useful for people who tend to have attachment patterns that bring them to anxiety and bring them to leaning in and bring them to dysregulation in a way that really you're thinking about your clients all the time. You are talking about your clients all the time. You're doing research about your clients all the time, right? And those types of life tendencies, I'm not judging it. I'm saying, what might that mean for the rest of your life? Right now, when it comes to how hard our clients are working, right? If we perceive that clients are unmotivated or they're not working hard enough, then I am going to imagine that that behavior or that ambivalence has served a purpose for that person or is actively serving a purpose for that person. So I'm not going to judge that, right? I'm not going to judge someone who I might perceive as unmotivated or not working hard enough, right? Because that's not mine to judge. And ambivalence is incredibly normal. It is incredibly natural when we're thinking about making changes in life. Let me see if I've got any other ones here. I recognize we're over time here. Allie, do we have time for any more or should we wrap up? You're muted.
I sure am. I think you got all the big ones that I sent. So I think we're good to wrap up. If anyone had already like hopped off, it's all fine if we go over. That's still accounted towards our 2 hour training. Gwen, thank you again so much. There's been a lot of really great feedbacks already. So again, you'll get your eval by the end of the day, and the recording and all the resources will go out to everyone next week. Also, I didn't mention, but if you did not meet the requirements for the CE credits, you'll also get an email telling you that you did not meet the requirements. So you'll get an email either way today. Awesome. Thanks, Gwen. Thanks, everyone. Have a great weekend. We'll see you on September 27th for the next webinar. Thank you all.
Thank you all.